Okay, now we're really getting to the home stretch, but we also have a lot more excitement this morning. This is one of our most popular aspects of our course, and so we're going to have a panel discussion, and we're going to have 3 panel members that are going to present complex cases in obesity treatment. In our final session, we have 3 specialists, and you're also invited to participate in the discussion about the treatment strategies for each patient through the interactive polling, and we'll also take audience questions after the sessions. Now, to introduce today's speakers on complex cases in obesity treatment, treating patients across the lifespan, our first presenter will be Dr. Nicholas Pennings. Dr. Pennings is board certified in family medicine and obesity medicine and a fellow of the OMA.
Hello, everybody. My name is Diana Pallin. I am an obesity medicine specialist, and unlike Dr. Feeney, this is the first time I present at this conference. Thank you, Dr. Feeney, by the way, for giving us a scientific explanation to why not all our patients like exercise and not all of them get the added benefits related to weight loss. I thought that was an amazing talk. I'm honored to share the stage with such great speakers, and I'm just going to jump into it and share one of my cases. I don't have any disclosures. So my patient is a 62-year-old white female with a BMI of 62. As you can see here, she has a long number of chronic medical conditions that can be barriers in a successful weight management. These include cardiac, metabolic, pulmonary, GI, and oncology. She was on a long list of medications to manage these conditions. The primary barrier in treating her obesity was the fact that she was receiving 200 units of insulin daily via an insulin pump. Another barrier is chronic respiratory insufficiency, oxygen dependent, which was severely limiting her physical activity. The patient was diagnosed with uterine leiomyosarcoma in 2012. She had surgery and radiation. She needed left lung lobectomy for metastasis 2 years later. This is when she was placed on a continuous oxygen source at 4 liters per minute. Liver biopsy revealed non-alcoholic fatty liver disease in 2017. She has a supportive family, 3 children and 6 grandchildren, and never smoked. As I mentioned earlier, the severe insulin resistance and decreased functional capacity are major barriers for this patient. In addition to this, other potential barriers include her anxiety and depression, if not well controlled, and medical costs. As you may already know, Medicare doesn't cover currently anti-obesity medication. On physical exam, vital signs were stable. On 4 liters of oxygen, her BMI was 62, melanopathic class 4, decreased breath sounds, both bases. She had a 2 out of 6 systolic ejection murmur. She had acanthosis nigricans, bilateral axillas, and neck folds, multiple skin tags indicative of insulin resistance. On body composition analysis, her body fat percentage was 54, and initial labs revealed a hemoglobin A1C of 7.5. Normal liver function tests, although those have been up and down and most of the time elevated, I was surprised by the fact that they were actually normal. She had an elevated serum calcitonin of 11.3. So we discussed different nutritional interventions, and she chose a ketogenic meal plan with 2 prescription meal replacements a day. Behavior counseling on differentiating between emotional versus physical hunger was provided on the initial visit. I adjusted her insulin basal rate setting by decreasing it to 2/3 of the initial dose and recommended that she only uses additional insulin if her blood glucose goes over 180. No meal coverage insulin was recommended, as her meals would include less than 10 carbohydrates each. I then saw her weekly and continued to adjust her insulin pump setting, and she was able to lose 40 pounds in the first 90 days. Then her weight loss plateaued. When we reviewed her food logs, it was clear that she was eating foods that were appropriate for a ketogenic diet. However, she was overeating. On further discussion, she admitted feeling without a purpose, depressed, and lonely. She stated that she has not been intimate with her husband since she was diagnosed with uterine cancer in 2012. She also stopped going to church after having the lung resection for pulmonary metastasis in 2014, as she was afraid of getting a respiratory infection. I discussed with her potential solutions for better control of her anxiety and depression. All right, so that's my first question. Which medications would you consider adding for better depression control? Patient is currently on escitalopram 20 milligrams daily. Very well, that was my choice as well. So I started her on bupropion, 150 milligrams extended release, which was very well tolerated, and then was increased to 300 milligrams a day. Patient lost another 23 pounds. Daily insulin requirements were decreased now to 80 units per day from the initial 200. Appetite control became a challenge again. Her calcitonin level, we repeated that level, and it was still elevated. So which anti-obesity medicine should be considered next? All right. So due to the elevated calcitonin level and her personal history of uterine cancer, the GLP-1 agonist was not selected. The goal was to control appetite and reduce the daily insulin requirements further while still controlling her blood glucose. Pramlintide has similar effects to GLP-1 agonists, but without the concerns related to medullary thyroid carcinoma. It was approved by Medicare. Again, this is a Medicare patient. It was approved by her insurance for coverage. Unfortunately, it was a tier 3 medication, and it was still too expensive for the patient to afford. As hunger was not controlled, I started her on a low-dose phentermine, and I did this after consulting with her cardiologist and pulmonary specialist, and she was then able to lose another 23 pounds when carbohydrate cravings and hunger became again a problem. So what medications would you use next? Okay, very interesting. So under different circumstances, again, I revisited the whole pramlintide idea, which was still too expensive. And I chose to add naltrexone, as she was already on 2,000 milligrams of metformin. And I felt that naltrexone, together with the Wellbutrin that she was already on, that made basically a substitute for a Contrave, and they do work very well together in controlling appetite. So I started her on 25 milligrams of naltrexone with dinner time, and this was later increased to 50 milligrams a day. Due to elevated blood pressure and severe constipation, which required an ER visit, phentermine was discontinued. Due to great control of her depression and transition to a weight maintenance phase, we were able to focus on behavior modification and assist her in managing her appetite without the phentermine. So as you can see here, she is now close to 100 pounds weight loss. Her resilience throughout this process has been remarkable, and she has used every tool recommended to her for lifestyle change and weight management. In summary, the patient has lost 99 pounds. Blood glucose is well controlled on a third of the initial dose of insulin. She now has a continuous blood sugar monitor. Pulmonary function tests are improved, including FEV1, forced vital capacity, and diffusing capacity. Total lung capacity has increased. Liver function tests are within normal limits. Depression is well controlled. And most importantly, her quality of life has significantly improved. She is now able to take care of her newborn grandson and 3 grandkids ages 4 to 12, which was not able to do before. I want to thank you for your time, and I'll take questions a little bit later.
Question for Dr. Pallin. Why didn't you use the GLP-1 because of a history of uterine cancer? We were not aware that that was a contraindication.
It's not. It's not. It's just be sensitive to the patient that's sitting in front of you, and talking to a cancer survivor, talking about potential secondary cancer or another cancer, the cancer itself was not a contraindication. The calcitonin elevation could not be, I couldn't dismiss that and start something that, personally I wasn't comfortable doing, because there's not a whole lot of things that can cause calcitonin in our bodies. So definitely, my hope is that we will find the reason why her calcitonin is elevated, and if she might already have something going on in her thyroid that was not obvious on the thyroid ultrasound. Remember, this woman started at the BMI of 62, so I'm not sure how sensitive that thyroid ultrasound was. So what if we're missing a medullary thyroid carcinoma that's already there? For me to put her on a GLP-1 agonist without investigating that, I don't think that's safe practice. And I still consider it, and I'm talking to her endocrinologist about it. But the uterine cancer was, and by the way, uterine cancer does not cause elevated calcitonin. That is not an explanation for her. It was just the fact that she's a cancer survivor.
For Dr. Stanford, a couple of questions. Why did you stop metformin, and how did you know that it wasn't sertraline and clonazepam that might have been contributing to the weight gain?
So notice when I put her on the metformin, she gained weight within a 2-month period. So she had been relatively stable where she was, and she gained that weight pretty quickly. So unfortunately, not always, but there are some occasions when patients will gain weight from an agent that you introduce. Notice when I stopped the agent, she no longer was gaining weight. Of course, I was adding another agent to then reduce weight, which was the whole reason she came to the weight center. So yes, there are occasionally patients that even with pharmacotherapy agents that we presume should cause weight loss, on average would cause weight loss, can potentially cause weight gain. And so that was my rationale for stopping metformin, as I noticed that she had been stable at that 60-pound gain for several years, and then just had an increase with introduction of that one agent, not the agents that she had been stable on for quite some time.
There were several questions on topiramate. One is, how long do you keep it for women of childbearing age? And then the second was, how often do you check pregnancy tests?
So I don't routinely check pregnancy tests. How long will I keep it on? If a woman is not actively trying to conceive and actually using forms of contraceptive that are effective, which means using barrier methods, IUD, et cetera, I just make sure that they are aware at the outset that we do not want to use topiramate if they are actively trying to conceive or are not using methods that can protect them from getting pregnant because of the risk of fetal anomalies with topiramate. I do use these medications in women that are of childbearing age. Some women will have an IUD placed because they have finished with their having children. But for those women that are not sure or may go into that realm, I tell them to let me know immediately, and we do titrate them off of the topiramate in preparation for potential pregnancy.
I would just also add to that as women lose weight, their fertility may increase, and so you have to counsel them on that, because some women will say, well, I can't get pregnant, but it's only because they've never gotten pregnant, not because they're unable to conceive. And when they lose weight, their fertility status changes, and they may get pregnant.
Yeah, pregnancy can be a side effect of weight loss.
So this next question is one I am really interested in hearing what you have to say about this one. How do you approach your colleagues who prescribed the weight-promoting medicines that you want to discontinue?
I have really great. So I say, hello, Dr. X. Thank you so much for your continued work with this patient. However, I'm extremely concerned about this medication, which appears to have contributed to some weight gain. I would love to consider an alternative agent if we can work together. So that would be a message that would go through me from Epic. And I would say that typically I usually get positive feedback. There are occasionally times when the doctors are unaware that their drug that they prescribed may have been a contributor, and so are interested in learning more. There are occasionally times when we have some angry colleagues that will come to, I can't believe you would mess with my drug. So, but I would say on average, people have a positive benefit. So basically what I do is at the conclusion of my note, I'll go through potential weight promoting meds, but then I'll copy the docs that I know were the prescribing docs to work on a potential strategy to help either change that medicine if I feel like it can be changed. The doctor may come back and say, look, we've tried these 10 agents and this is the one we have to use, after which I would consider the introduction of an anti-obesity medication potentially to help mitigate that weight gain.
And I would agree with that too. I think the most important thing is communication, to communicate with the other provider, let them know, what your concerns are. They very often are not aware of medications that cause weight gain or the impact of a medication on weight. It's not part of the thought process in prescribing, and it's not part of their consideration in the side effect profile of a medication for most physicians. So most physicians do appreciate the education and are willing to work with you.
I live in a small community, so I pick up the phone and I talk to the provider. And I find that that goes much more times better than via text and email, because there's a lot of things that get missed in that communication type. So that helps.
There's over 3,500 physicians at Mass General alone. I will not be able to call them, but I like the idea or notion. Yes.
Finally, there's a couple more questions on phentermine. Do you ever alternate phentermine, so 1 week on, 1 week off? And for long term, would you stay with 37.5, or do you reduce to 15 or Lomera over long term?
I don't use intermittent dosing for the most part. Some people, I've used it around kind of different times in life when they have more challenges. So if somebody really has a struggle when they're traveling, or certain times I might use it intermittently occasionally, but for the most part, when I prescribe it, and I use whatever dose works for them. I do reconsider doses, and if people tell me that if I forgot to take it for a week and I feel fine and they want to try off of it, by all means, we try off of it. So I think that you have to treat each patient individually, but I wouldn't hesitate as long as you don't have any legal restrictions around prescribing it to use it for longer term. You do have to monitor the patient, you have to monitor their blood pressure, you have to see them on a regular basis, you have to make sure they're not having any side effects from it. So I think the monitoring is still a very important part of it. It's not something you just prescribe haphazardly. But I also don't feel uncomfortable about using it longer term.
And the final.
I use it the same way Dr. Pannings mentioned. However, in maintenance, I try to find the lowest dose that would allow them to control appetite and maintain a stable weight. And what happens many times is that I have patients that they are doing fantastic during the week and the weekends are challenging. So they actually only use the phentermine in the weekend and take a break from it during the week. Or the opposite. There are patients that say, the weekends are great and the weekdays are awful. So I allow the patient to use it as needed, especially in maintenance. Usually in active weight loss, I try to do like a daily dose, but in maintenance, I found that very useful to the patient.
And the final question was, if you do have somebody with treatment-resistant depression and they're on bupropion and it's not working well enough, do you have a go-to that you would do?
If bupropion is not working?
So is there a go-to agent, basically? So,
Well, I usually use naltrexone first. I mean, that's studied and works very well as an add-on agent. But I consider other ones as well.
I would concur with that. I think that each person's depression is also very different in terms of how they respond. Some people are non-responders to bupropion, for example, and need several additional agents, ones that I consider to be weight promoting. So I'm typically working in conjunction with their psychiatrist to find a regimen based upon their history. Also, that would be efficacious. Obviously, we know the most neutral of the SSRIs is fluoxetine, so that might be a go-to additional agent. If I were picking between the agents, that would be probably my go-to.
And I misunderstood that. I thought you were talking about for weight management. Yes, I would concur with that. And be very wary of the atypical antipsychotics because some of those can be notorious for weight gain.
With that, let's give our panel a round of applause.